Welcome back, everyone. It's a pleasure to be with you again and to give our lecture today in the Foundation series on risks and harms of cannabis. These are my disclosures again, no differences from the earlier days. And I want to give particular acknowledgements today to 4 trainees I've worked with who contributed in major ways to some of the findings I'll be reporting today. I'll be describing some of the research that's coming out of my lab. Max Owens was a PhD student with me some years back. Jasmine Turner was a postdoctoral fellow with the DeGroote Center. Tashia Petker did her master's degree in the McMaster Clinical Psychology program, and Melissa Parlar was a clinical psychology resident, and I'll be presenting some of the published work that they led. All are outstanding students, and I feel fortunate to be sharing their work with you. So what I'm going to talk about today is a somewhat selective review of cannabis risks and harms. This is a big topic. It's not something that you can cover in a single lecture, but the goal is to zero in on what I hope are some key areas. And I'm going to start with a framework for thinking about the kind of waterfront we're trying to cover in terms of characterizing risks and harms. We're going to talk about cannabis use disorder, the clinical diagnosis of problematic cannabis use. We're going to talk about cannabis and cognition. This is a hot topic, both in consideration of harms associated with recreational use and medical use. And then I'm going to talk a bit about the blurred lines between medical and recreational use, because that is a really tricky issue in terms of how people use cannabis. Stacy Gruber highlighted the quite different effects in exclusively medical users, but that is not always the pattern of use we see. So I'll be presenting some findings in that area, and then I'll finish with some conclusions. So going back to our kind of key research approach here, and I think this is actually very fitting given the title of Dr. Hurd's talk, The Yin and Yang of Cannabis in Relation to Opioid Use Disorder. We really think of cannabis science as being the yin and yang of benefits versus harms in the context of the DeGroote Center. How do we understand systematically if there are benefits, and how do we then consider those in the context of harms? And more generally, when it comes to cannabis, how do we understand benefits and harms in the recreational context too? So these are our priority areas. I presented these on Monday also, and obviously they haven't changed, but they do very much shape the priorities for this talk. I'm going to be really zeroing in on adverse consequences of cannabis use. As I said, cannabis use disorder, cognitive consequences, and these are 2 of our priority areas. I'll also touch on psychiatric symptoms and lung harms too. We won't be talking about therapeutic benefits at all or legalization effects. So in terms of thinking about risks and harms, one of the ways that can be helpful in terms of thinking about the overall domain is thinking about the acute effects of cannabis and versus the chronic effects, no pun intended. The acute effects being what's happening while people are actively under the influence of cannabis at a biologically meaningful level, whether it be in the context of intoxication or, for that matter, treating a medical condition, as opposed to taking cannabis for long periods of time and the basically accumulated risks in terms of chronic risks. So when it comes to acute risks, one of the most well-established is that of motor or performance impairment. Not unlike alcohol, cannabis intoxication certainly is associated with performance impairments and is robustly associated with motor vehicle accidents. Equally, there are acute impacts on cognition in terms of direct effects on, for example, attention or recall. And then the other thing that is relevant, but is not actually discussed all that much, is basically the overdose syndrome or the toxidrome of over-consuming cannabis. And people often highlight the fact that from an overdose standpoint, cannabis is comparatively benign relative to other psychoactive drugs, insofar as it effectively has no known lethal dose for healthy adults. Unlike opioids, unlike alcohol for that matter, unlike stimulants. So the risk of overdose leading to respiratory depression and death, or another medical consequence in death, is exceedingly low, but that doesn't mean you can't overdose on cannabis. One of the persistent myths is you can't overdose on cannabis, and certainly if you overconsume, especially if you consume a lot of edibles, you can feel extremely unwell. It can induce a delirious state or psychotic symptoms. It can require medical management of this very unpleasant state that fortunately is not life-threatening. When we think about chronic risks of using over time, there's cannabis use disorder, that is developing a substance use disorder when it comes to cannabis. There are enduring effects on cognition that can persist beyond just a single episode and result in more global deficits that can be, in some cases, long-standing, in some cases, short-term. We'll talk about duration over the course of the talk. We know that there's a robust association between cannabis use and the likelihood of developing a psychotic disorder. We know a lot more about the correlation than we do know about the causation. This is a really important area of research. It appears to be most relevant to people who have a very dense family history for psychotic disorders, but the reality is we don't really understand the mechanisms, but we do know that the two are associated with each other. We know that cannabis can also exacerbate some psychiatric symptoms. Many people report using cannabis when they're feeling bad, for using for negatively reinforcing purposes to feel less bad, sometimes using it specifically to treat anxiety or depression or PTSD symptoms. But there is evidence also over time that kind of pattern can lead to actually exacerbation of those same psychiatric symptoms. There are also associations epidemiologically with self-harm and suicidality. I presented some of the work specifically on veterans on Monday, but this has been demonstrated in other populations also. Again, like psychotic disorders, here we have a pretty clear sense that there's a correlation. It's not clear if there's a causation or if there may be a confounding or third variable playing a role. Most people continue to use cannabis, at least recreationally, by inhaling it, often from as a dried flower product rather than vaping it. As a result, there is consistent evidence that cannabis use via inhalation is associated with chronic bronchitis. It does not appear to be associated with lung cancer akin to tobacco, which is great news. However, the risks are probably incompletely understood there, because most people who use cannabis use vastly less cannabis than individuals who have tobacco use disorder, who smoke often a pack or more a day. And so, especially in very heavy users, it may be that that risk is present and we just haven't detected it yet. And this would be particularly relevant to medical users who do use on a frequent basis. And then the last chronic risk is cannabinoid hyperemesis syndrome, a syndrome that used to be extremely rare, but now is much more common, perhaps because of the much higher levels of THC in contemporary cannabis products. This refers to a syndrome characterized by gastrointestinal pain, discomfort, nausea, frequent vomiting. The syndrome is surprisingly only relieved by taking very hot showers. And it tends to present in individuals who are heavy daily cannabis users. Ultimately, it remits with discontinuation of cannabis. It's now a much more common phenomenon, but is not well understood and seems to be a function of some sort of biological adaptation that takes place over the course of chronic use. So there are a lot of different established risks, both acute and chronic. And I'm not going to try to do a deep dive on all of these today, simply because it would be impossible to do so. Excuse me. What I'm going to do is really zero in on what I think are going to be the most important ones for the purposes of our conference: cannabis use disorder and adverse impacts of cannabis on cognition. So let's start by talking about cannabis use disorder. Cannabis use disorder is like other substance use disorders. And when it comes to clinical management, one of the great myths out there is that people can't become addicted to cannabis. And the term addiction is widely understood, but the reality is it's not a clinical term. It's not a technical term used in medicine. When we think about substance misuse, this is a heuristic to kind of run through the way we often characterize different levels of use. Often for alcohol, cannabis, and other substances, we will identify certain boundaries that are associated with risk. So the largest category is individuals who are using at risky levels. This is often determined using screening questionnaires. In the case of cannabis, it might be the Cannabis Use Disorder Identification Test, the Acute. And basically, these are ways of defining levels of use that reflect increased risk for adverse consequences. Doesn't speak to whether or not there's necessarily a diagnosable condition, so much as it provides a way of defining people who are at elevated risk of experiencing adverse consequences. Among people who are using at risky levels, a subset are likely to meet criteria for a substance use disorder, which is a medical diagnosis given by a healthcare professional, typically a psychiatrist, a psychologist, or another mental health care professional. Substance use disorder in DSM-5 refers to basically anyone who exceeds 2 or more symptoms in the described syndrome. Addiction, again, is not a clinical term, and it's described here as having kind of porous boundaries, because as a field, we haven't defined exactly what we mean by addiction. What it's often used to denote is moderate to severe substance use disorder. Most people don't think that mild substance use disorder necessarily would be considered what we colloquially think of as addiction. But in any case, it's important to know the distinction that substance use disorder is the clinical diagnosis given to reflect clinically significant impairment or distress associated with cannabis use. It's not necessarily addiction, although addiction does fall within that category. So those are the kind of categorical Russian nesting dolls, if you will. What we're actually talking about in terms of symptoms is those 11 different symptoms that you can have. So this is a lot all at once. These are the 11 symptoms, and the definition of cannabis use disorder would be the presence of at least 2 over the last year. So rather than going through all 11 one by one, they can, in a lot of ways, be chunked together. So the first 4 here, using cannabis in larger amounts over a longer period of time than intended, spending a lot of time obtaining, using, or recovering from cannabis, trying to cut down unsuccessfully, experiencing intrusive cravings. All of these symptoms reflect essentially an inability to regulate one's cannabis consumption. That is, loss of control over one's ability over one's volition when it comes to cannabis. Then another set of symptoms primarily focus on adverse consequences. So using despite the knowledge that it's making a physical or a mental health problem get worse, not being able to fulfill role obligations at work, school, or home, giving up other activities eliminating alternative reinforcers in your life, or using cannabis in situations where it's physically hazardous, like using it when you're driving, or using and then driving. And these all reflect consumption of cannabis in spite of adverse consequences. And then the last two symptoms are tolerance, needing, essentially not experiencing the same effect with the same amount of cannabis, or needing to consume more over time to achieve that intoxication or desired effect, or withdrawal, which is the reciprocal. And this is defined as the characteristic withdrawal syndrome for the drug, or a person who needs to use cannabis to relieve or avoid withdrawal symptoms. So here, what we're really talking about is physiological dependence. That is, the body has adapted to the persistent presence of cannabis, and as a result, those adaptations have led to tolerance and withdrawal. And again, a person only needs to have 2 or more symptoms to technically meet criteria. What we're talking about in terms of withdrawal syndrome here, the quote unquote, the prototypical withdrawal syndrome, is 3 or more of the following signs and symptoms. Another, unfortunately, persistent myth is that you can't be physically addicted to cannabis, or you can't be physically dependent on cannabis. That's not true. There's a well-documented, well-studied withdrawal syndrome. It certainly seems to be much more common nowadays, again, in part perhaps because of the much higher THC levels. It mostly includes intrusive negative affective states, so feeling anxious, angry, aggressive, irritable, restless, depressed. There's also typically decreased appetite or weight loss, and then some physical symptoms also, so abdominal pain, shakiness, sweating, fever, chills, or headache. So if a person discontinues their heavy cannabis use and experiences 3 or more of these symptoms, we would consider them having met the criteria for cannabis withdrawal. So why does this happen? Well, the development of cannabis use disorder in a lot of ways can be understood within the broader framework of a biopsychosocial model for understanding addictive behavior. And I'm not going to do a deep dive on the biopsychosocial model. What I'm going to focus on more in the context of cannabis use disorder is the more kind of narrow understanding of how it develops, in the sense that it really is driven largely by neuroadaptations in the brain, and specifically neuroadaptations in the endocannabinoid system. This is a figure that you hopefully remember from Monday's talk that shows the distribution of CB1 receptors in the brain. And by chronically, or again, persistently stimulating these receptors and these regions of the brain with exogenous cannabinoids, THC, for example, there's an upregulation that happens. And basically, there are neuroadaptations that change as the brain adapts to the exposure, the pharmacological exposure to THC. So what we see when we look at PET scans, this is a scan looking at CB1 receptors, and specifically individuals with cannabis use disorder compared to controls, and where we see significantly reduced levels of CB1 receptors because the brain has adapted by virtue of that persistent chronic exposure. So just like the previous slide, you can see these decreases are globally where the CB1 receptor is most preferentially expressed. So prefrontal cortex, occipital lobe, visual cortex, areas of the anterior cingulate, for example, also. No changes really subcortically, but more or less across the cortex, there are lower levels of CB1 receptor. And then if people abstain from cannabis, as they did in this study, we see a rebound. So these were individuals who then were biochemically verified as having abstained for approximately a month. And this is the rebound in the number of CB1 receptors. So this is the increase, the renormalization in anterior cingulate, amygdala, insular cortex, occipital lobe, parietal lobe, posterior cingulate, prefrontal cortex, parahippocampal gyrus. And what's really critical here is as you probably gather, these are really important regions for executive functioning in the case of prefrontal cortex, emotional in the case of functioning in the case of amygdala. So we see a recalibration after people stop using, but the reality is over the course of heavy use, the brain downregulates its CB1 receptors, and that's responsible for some of the features of cannabis use disorder. Here's a second study that shows very similar findings. So this is again comparing cannabis dependent individuals relative to healthy controls. And what you can see is that the healthy controls have lots of CB1 receptors in the regions that we would expect. The cannabis dependent individuals have a much lower overall receptor density. That's significantly different. And that if you look region by region, in many of these regions that are important for cognitive and emotional functioning, like amygdala, for example, or frontal lobe, we see significantly lower levels of CB1 receptor. And again, fortunately, after people abstain, these are data showing the 28-day scan compared to the baseline scan. The healthy controls show no differences. Nothing's changed. They're still not using cannabis. Fortunately, we see some rebound in the cannabis-dependent individuals, a gradual increase. This is a very small study, only about a dozen people in each group here. But we do see basically some return of function in terms of the number of CB1 receptors. In terms of how common cannabis use disorder is, I showed you this figure on Monday showing that Canada has one of the highest rates of overall cannabis use. Fortunately, the rates of cannabis use disorder are relatively low. About 7% of Canadians over the course of their life are anticipated to experience cannabis use disorder. So between 1 in 20 and 1 in 10, the 12-month prevalence is around 1%. So that's in the larger epidemiological picture, a relatively small proportion of the population, and certainly a small percentage of the individuals using cannabis. If we look in the US, our most natural comparator here in terms of a population level, relatively high rate of use, in the United States, the lifetime prevalence is pretty similar, around 6.27% in a recent estimate. That's a few years old now. The 12-month prevalences have varied and have ranged in terms of about 1.5 to 2.9. There is some concern that the 12-month prevalence seems to be ticking up along with overall use. And certainly an increase from 1.5 to 2.9, this is in two different studies, would be quite substantial, reflecting basically a doubling. But in general, the overall prevalence of cannabis use disorder is relatively low in the general population and reflects a small minority of individuals who use cannabis. The other way to look at this is to try to contextualize the risk and harm. And so I'm going to share with you results from two studies that I think do a nice job doing this. The first study is from a huge epidemiological survey that looked at the prevalence of dependence across, I think, more than 43,000 people. And they also did, among many, many analyses, they did an analysis of what the percentage of dependence was. This is when the definition was of dependence in DSM-4, what the percentage was among the people who are actively using the substance. So not for the general population, but for people who are using the drug, what's the relative level of prevalence? And what you can see is that actually the highest level of clinically significant problems is for tobacco. So about half of people who reported being smokers met criteria for tobacco use disorder, about a quarter for cocaine and heroin. Alcohol was 6%, so approaching 1 in 20, and cannabis was a little bit higher, around 8%. So between 1 in 20 and 1 in 10. So if we look at this, we see that there's a meaningful number of individuals who experience clinically significant cannabis problems, but it's probably more similar to alcohol than it is to quote unquote harder drugs like stimulants or opioids. And indeed, in this case, tobacco actually had the highest rate. The second finding that I think is interesting, here's the highlight of cannabis. The second finding, again from the same massive epidemiological survey, looked at the lifetime substance use disorder likelihood. That is, if you ever use the drug, how likely is it that you will go on to then develop a substance use disorder at some point in your life? Obviously, most people you will try alcohol at some point. Most people will not try stimulants or opioids at some point in their lives. But this is another way of kind of contextualizing the level of risk. And what we find, again, is that cannabis actually rates pretty mildly in this context. Tobacco has the highest likelihood of ever reaching the criteria for a substance use disorder. About 2/3 of ever smokers will then at some point meet criteria for a tobacco use disorder. Alcohol and cocaine were both around 1 in 5 individuals at some point in their life meeting criteria for an alcohol or stimulant use disorder. For cannabis, it was relatively low. It was less than 1 in 10, around 9%. So cannabis use disorder is a real thing. It is driven by broadly biopsychosocial factors, but the kind of narrow features are largely based on the upregulation of CB1 receptors. Fortunately, it does not affect very large numbers of people and only affects a small proportion of active users. What about treatment? Well, I'm not going to do a deep dive into treatment. There are evidence-based strategies for treating cannabis use disorder. At this point, they're primarily psychological. So there's good evidence that motivational enhancement therapy, also called motivational interviewing, can be helpful. There's some evidence that cognitive behavioral therapy can be helpful, and contingency management. Also, contingency management is when incentives are directly used to encourage people to not use and to engage in other forms of treatment. At this stage, there are no approved pharmacological treatments for cannabis use disorder. There's a lot of interest. There are a lot of compounds being studied, but there are no FDA, no Health Canada approved medications at this point. So this is certainly a concern for the field because there is a need for more treatments. And there are no silver bullets for treating substance use disorders, but the more evidence-based strategies you have, the better. And combining pharmacological and psychological interventions often provides the best outcomes overall. So let's move on to the second chapter and talk a bit about cannabis and cognition. So why talk about cannabis and cognition? Well, there's actually a number of reasons. The first is that, as we've talked about before, the endocannabinoid system is deeply, intimately linked to cognition. And now you've seen this figure a number of times. I won't belabor it further, but the endocannabinoid system is so central to cognition, it makes sense to zero in on it as a possible domain for cognitive consequences. More important than that is it's relevant to everyone who uses cannabis. It's not just people who have cannabis use disorder. It's relevant to recreational users. It's relevant to medical users, especially because medical users are more likely to use on a frequent basis and to use larger overall volumes of cannabis products. And then the other reason to be interested in this is, unfortunately, there's a lot of inconsistency in the literature. So if possible, if here at the DeGroote Center, if we can do work that sheds light on the link between cannabis and cognition, this could be really useful in a fairly conflicted area of the scientific literature. So what do we know about cannabis and cognition? Well, what I'm going to do is walk through a well-conducted systematic review that came out now just about 5 years ago that basically boiled down nearly 6,000 records in bibliographic databases into 105 different studies that examined neuropsychological performance, essentially, and cannabis use. And what was found by this team was a number of consistent findings and a number of inconsistent findings. So there's a lot going on here. Let me walk you through this table. Here are the many different cognitive domains that were studied. They also then were able to parse the studies into studies looking at acute effects, chronic effects, whether or not those effects continued after people had discontinued use, and other features of the study that sometimes affected the strength or the weakness of their findings. So the first thing that they found was that when it came to acute effects, there was quite strong evidence that cannabis directly negatively impacts verbal learning and memory, attention, psychomotor function, and inhibitory control, or essentially your ability to stop yourself from an arising response, something that's really important when it comes to, for example, driving a car if you see something coming out of the corner of your eye. So there were quite a lot of equivocal findings also, but these seem to be the most consistent findings as indicated by these multiple plus signs. That's going to be common throughout. What about chronic effects? Well, when it comes to chronic effects, the most consistent findings seems to be, again, verbal learning and memory, attention, attentional bias for cannabis-related stimuli. Inhibition does not appear to be significantly affected, and some modest residual consequences or chronic consequences in terms of psychomotor function. These are still relevant for things like performance in terms of driving, but are somewhat different from the acute effects. Which of these persist beyond after a person stops using cannabis? Well, this is where things get really murky. Here you can see plus minus, plus minus, minus, plus minus. Not applicable because there weren't any studies, plus minus, plus minus. So a quite equivocal literature in terms of understanding the persistence, how long these effects last. And then the last thing to highlight is that there are many different factors that were looked at that influence the nature of these findings. So there's a lot of heterogeneity in the literature, and there are a lot of what we often call moderating variables that change whether or not an effect is detected or not. So in summary, we've got quite a lot of inconsistency. There seems to be some small study or what's called publication bias insofar as in their review, small studies that found large effects were quite common. And there may well be some measurement error because some of these constructs are assessed using very different neuropsychological tests. And then finally, many of the studies, again, because they were quite small, were not able to adjust for many of the covariates or possible confounding or nuisance variables that you would want to include. And some of this has to do with just the challenges of doing neurocognitive testing in the context of cannabis research. Neurocognitive testing takes a long time. It's intensive. It largely relies on in-person assessments that can be quite onerous for the individual. And so many of the studies tend to be quite small. And what we've tried to do in the center is conduct a number of studies that increase the sample size dramatically in the hope of trying to address some of these inconsistencies and challenges that might be coming about because of small studies or inability to adjust for an adequate number of confounders like drinking or smoking or other factors. So to start with, what do we know about what people think about cannabis? Well, when it comes to cognition, these are data from a study we did on cognitive expectations in a large sample of community adults. This is how they rated in general positive effects and negative effects for cannabis. And most of these you can see in terms of the negative effects have to do with cognition. People believe that in general, it reduces reaction time, impairs memory, reduces coordination, attention, concentration, balance, possibly ambition. These are just attributions, but people tend to believe that cannabis has a negative consequence when it comes to cognition. That's not to say that there aren't positive consequences too, but these were just general attributions in a large population sample. If we split them into cannabis users versus non-users, in general, cannabis users had more positive attributions and less negative attributions, but everything was in the same direction. Users and non-users all basically agreed that they believe that cannabis has some noticeable effects on cognition, albeit to a smaller extent among people who are active cannabis users. All of these differ significantly from zero, indicating that they are endorsing these beliefs. What about objectively? So our first study, in terms of objective neuropsych testing, was done using the Human Connectome Project database. which is a large open science project looking at interconnections between different brain regions. And one of the nice things about the project is it has a very rich neuropsychological battery that's included. And in this case, we were able to obtain data for more than 1,100 individuals who all did this intensive in-person neuropsychological testing battery. And these are the different tests. These are the different cognitive functions: memory, inhibitory control, fluid intelligence, processing speed, dexterity, impulsivity as measured by delay discounting. So lots of different cognitive processes. And we looked at these performance on these tests, looking at the presence of cannabis use disorder, lifetime cannabis use, age of first use, and whether or not people still had THC in their urine. So what we found was actually there were relatively few effects when we looked at these 4 different domains. So we only found significant associations after we adjusted for a dozen or more possible confounding variables. We found that in the first case, having a history of cannabis use disorder was associated with lower overall fluid intelligence. This was a small effect size, but it was nonetheless statistically significant. And we found that having THC in your urine, suggesting recent use and or heavy use, was associated with lower processing speed and poor nonverbal episodic memory. So that would be basically a recall task. So in this case, it was really the bulk of the findings were specific to THC being on board or cannabis use disorder. We also went one step further. We looked inside the Human Connectome project at the brain activity during another working memory task. So in this case, we looked at what's called visual NBAC. It's a measure of your ability to remember on a screen just the picture you saw 2 pictures ago relative to the picture you're looking at right now. And we conducted a study first characterizing the neural signature of working memory performance in the Human Connectome project sample. We found pretty standard effects. We found supplementary motor area being implicated, right middle frontal gyrus, bilateral insula, and decreases in activity in medial orbitofrontal cortex, or depending on how you define it, ventromedial prefrontal cortex, as well as posterior cingulate. So these would be your task negative suppressions of the default mode network, whereas the task positive regions were, again, bilateral insula, central medial frontal gyrus, supplementary motor area, some posterior parietal cortex. And then what we looked at again was presence of cannabis use disorder, number of lifetime uses, age of first use, and whether or not people had any a positive urine test for THC at the time of testing. And what we found was that the only significant difference was based on THC status. Again, we covaried for numerous variables. What we found was that if people had THC in their urine, they showed significantly worse working memory performance in the scanner in terms of the behavior, but they also showed significantly lower brain activity in central middle frontal gyrus and significantly greater brain activity in ventromedial prefrontal cortex. And so what we basically see are decreases in activity in the regions that you need to do the task well, and increases in the task negative regions that the brain shuts down when you're doing the task well. The areas that are part of default mode network, you're kind of wandering brain network that is largely turned off when you're engaged in a cognitively intensive task. So we see that THC on board seems to be the critical variable here. When we actually modeled this using mediational analyses, what we found was that the decreases in the THC in relation to working memory accuracy was jointly mediated by decreases in activity in the task positive regions and increases in the brain activity in the task negative regions that collectively were responsible for those deficits. So what seems to be the case is that heavy or recent cannabis use is associated with residual deficits or decrements in working memory performance, both because of less engagement of the regions you need to be successful and more interruption from the regions you need to be quiet, basically. So this reminds us of some other abstinence effects that are really important. And I'm going to go back to a couple of really influential earlier studies. This is a study, there's a lot going on here, but it's a study looking at cognition in cannabis users, active cannabis users, in comparison to controls who used no cannabis versus former cannabis users, also versus controls, looking over 28 days of abstinence. And these are 3 different neuropsychological tests and a variety of other neuropsychological tests that were administered after 28 days of biochemically verified abstinence. And the thing that jumps out right away is that if you look at former cannabis users versus non-cannabis users, you actually see no differences at any point over the month, suggesting that once you stop using cannabis and it's fully flushed out of your system, most of the neuropsychological effects are no longer detectable. If you look over here also, again, at 28 days post-abstinence, there's no difference in contrasting the former users with the control participants. That's the reference category here. On the other hand, if we go to the active cannabis users versus controls, you can see at baseline, at day 0, they show significant decrements at day 1, at day 7, 0 and 7 here, 0, 1, and 7 here. But by day 28, those decrements have gone away, which is good news. A month of abstinence basically reverses these cognitive consequences. And the same is true over here. Using these very intensive cognitive tests, after a month of abstinence, there's no difference between the active cannabis users and the controls or former cannabis users. So it seems that abstinence is a critical factor in terms of neurocognitive performance. One last study I'd like to show you is a meta-analysis that looked at cannabis and cognition in adolescents. And they were able to aggregate a lot of studies together and found moderate effects overall. But what they also found that was really interesting was that if you then binned the studies based on abstinence, either into no abstinence required, less than 72 days, just 3 days of abstinence, or more than 3 days of abstinence, the effect sizes, this is relative to 0, the amount of decrement in terms of neuropsych performance was significant in both of these cases, but was effectively non-significant with just 3 days of abstinence, although clearly slightly lower, but now overlapping with 0 in studies using a 3 or more day washout period. So it seems like we're seeing more and more evidence that there are chronic effects, in the sense that for people who are active users, especially if you see evidence in their urine drug screen, there will still be some cognitive effects, but longer term abstinence seems to reverse those cognitive consequences. We've done a number of other neuropsych studies, and I'm just going to show several more to you to reveal some more trends. We looked at cannabis and cognition in almost 1,000 community adults recruited from the Hamilton area. We covaried for age, sex, income, drinking, smoking. We used a similarly long battery. Again, we actually found in most cases non-significant associations between cannabis use and cognition. What we did see was that people were more impulsive in terms of overvaluing smaller immediate rewards, and they reported higher levels of ADHD symptoms, both hyperactive and inattentive symptoms. And this was really driven by our measure called the Acute, again, the Cannabis Use Disorder Identification Test. We looked at age of first use also. We didn't have urinary THC in this study, but we looked at whether or not age of first use would independently or interactively increase the impact. In this case, we saw no effect of age of first use. So again, most areas of cognition spared, but some selective deficits observed in this adult sample We've done 2 studies in emerging adults who are heavy drinkers, one in Canada and one in the US. And what we found, again, was that the effects seem to be localized around this overvaluation of immediate rewards. All of these areas of cognition showed no differences, somewhat surprisingly for working memory, given our other findings. But when it came to impulsivity, we saw significant differences. And again, here we saw greater reports of ADHD hyperactivity. This was all linked to severity on the Acute. There was no relationship to age of first use, again, either independently or interactively. Finally, this is our US study. It's a similar cohort, heavy drinkers who are also frequently cannabis users, about 600 individuals. We included a laundry list of nuisance variables to adjust for. Here, we do see further evidence of working memory being impaired, so a weak effect, but an association nonetheless. Impulsivity over and over again is elevated in relation to cannabis involvement, as is ADHD hyperactivity. So, and again, age of first use, this is now the 3rd study where we're not finding any independent or interactive associations of age of first use, at least in these cohorts. I know that this differs somewhat from Stacy Gruber's findings. I think that there's clearly a more complex story when it comes to age of first use. What's really interesting here is that these effects seem to be driven, at least in part, in terms of the very heavy users, the daily or multiple times daily users, who probably also would have a positive urine drug screen. Here we see greater ADHD, mostly in the heavier users. In the American sample, the elevation was present for the occasional users also, not just the daily users. But it does seem like occasional use, at least in our Canadian sample, was not associated with any elevation in terms of ADHD symptoms. But there is this consistent linkage. So one of the questions we're undertaking now is cannabis associated with developing what are at least perceived to be ADHD-like symptoms? Is it contributing to the elevations? Is it the other way around? Are people who have ADHD diagnosed, it's required to be diagnosed in childhood, are they more likely to seek out cannabis, possibly to self-medicate, or possibly because of common vulnerabilities within the reward systems of the brain? And then, of course, there could be a 3rd variable that's responsible for both. So it may be that these two are not causally related to each other, but possibly it is some kind of shared diathesis, as I alluded to before, in terms of reward sensitivity, possibly genetic factors that both predispose a person to both ADHD and cannabis. So this seems to be a pretty consistent link in our studies. Right now, we seem to have fairly robust correlation. We do not have causation by any means. These are cross-sectional studies. We're looking forward to unpacking these over time and in more experimental studies. So the last part of my talk is going to be on just the blurred lines that exist in terms of cannabis and medical and recreational use. And this is where things get tricky because, again, we have this surge in numbers of medical cannabis users. I showed these data on Monday. The numbers have continued to rise, although they've flattened somewhat since then. But we have about 350,000 authorized medical cannabis users. But when we actually look at community samples, we have good reason to believe that there actually is a much larger number out there than that, and that there's quite a lot of murkiness between medical use and recreational use. So we began a cohort study investigating the impacts of cannabis legalization, recruiting about 1,500 individuals prior to legalization. And we've been studying them for some time now, including lots of questions about cannabis use, recreational use, medical use. And so within this group of 1,502 people, I'm going to share with you some data on the cannabis users, both recreational and medical cannabis users, about 700 people. And of these individuals, 435 said they only use for recreational purposes. 274, a fairly large proportion, said they use for medical purposes. And then subgroups reported either medical only or medical and recreational use. So if we break this down, 60% reported recreational use only, nearly 40% reported some level of medical use, so some use to treat a symptom or otherwise address some aspect of healthcare. So 80% of our medical cannabis users in this sample were actually dual motives users. They were using both for medical and recreational purposes simultaneously. And indeed, only 7% were medical only users. This is somewhat troubling because if you think about other areas, if you ask people about their benzodiazepine use, you'd be very troubled if they said, well, I use it as it's prescribed, but I also use it to get high when I feel like it on the weekend. So if you ask people about their opioid use, someone who said that they use it both to manage their chronic pain and also to feel good recreationally would be a big red flag from a clinical standpoint. So we have high rates of dual motives users, and the rates of physician authorizations were quite low. So even in our medical only group, only 44%, less than half, had gone to a physician to get the authorization. And only 1 in 5, fewer than 1 in 5 in the dual motives group had actually got an authorization. So there's a very large proportion of people who appear to be using cannabis for medical purposes without a physician authorization, and often blurring the lines between medical and recreational use. So how do these people differ from each other? There's a lot going on here, but here are all of our cannabis users, the recreational users, and then within their medical users, all of them, the medical only and the dual motives users. And rather than go through the whole table, the first thing I'll highlight is that the medical cannabis users typically use much more frequently than recreational cannabis users. So 40% around are using daily as opposed to much lower rates. So medical cannabis users consume much more frequently, and dual motives users consume even more frequently still. Medical cannabis users typically use, or medical only users typically use products other than dried flower. Medical plus recreational typically use dried flower and typically use considerably more than recreational users. And medical users more commonly knew what was in their cannabis, and the medical only users most commonly use low THC, high CBD products, whereas the medical plus recreational users are using typically high THC products, and the recreational cannabis users generally didn't know what they were consuming in terms of constituents. And then the last piece here are the Acute scores, which is important because this can indicate potential problems. It's imperfect because some of the items capture frequency, but it can give you a sense for potential problems. And here we see that the medical cannabis users have the higher Acute scores, and the dual motives users have the highest Acute scores. We can't be sure that that means they also have cannabis use disorder. This is just a screening test, but it certainly suggests that there could well be more problematic use in those subpopulations. What about differences in what they're using for? So these are the different conditions that the medical only and medical plus rec were using for. If we look at areas where medical plus rec was more common than medical only, it's for anxiety, depression, PTSD, sleep problems, acute pain, and headaches. So these are all conditions that there was a much higher rate of use for medical plus recreational users. In contrast, medical only users tended to be more commonly reporting arthritis, chronic pain, and muscle spasms. So you can see that these are quite different constituencies. These constituencies look different in a lot of different ways. And in this case, they're using more frequently, using more product, using higher THC products, and using for mental health or acute pain more commonly for the medical plus recreational users. So let's draw some conclusions now. So one of the things to think about, I think, is not just the black and white cannabis questions, but the overall context here and balancing risks and harms. And so one last piece of data I'd like to share is from a multi-decision criteria study of psychopharmacology, addiction, and substance use professionals, in which they were given information about the harms to the individual for different drugs and the harms to other people from different drugs, a variety of different drugs. And then they rated those drugs in terms of where the greatest harm was felt. Basically a report card for different psychoactive drugs. And what we see is that cannabis lands pretty much right in the middle. There's an approximately equal balance of harm to users versus harm to others. It's considered less harmful than a variety of drugs, more harmful than a number of other ones. The most harmful drug, when you consider all the harms involved to others and to self, is actually alcohol, another legal drug, where harm to others in the form of, for example, car accidents, physical assaults, sexual assaults, domestic violence, homicide, suicide, etc., are extremely high. So when we think about the risks and harms of cannabis, I think it's useful to think about it. The risks and harms are real. They are non-trivial, but compared to other areas, they may not be as significant. And it's worth balancing that to consider the yin and the yang, so to speak. When we think about cannabis use disorder, this will be kind of the through line. Cannabis use disorder is not a myth. It's real. It happens to a non-trivial number of individuals, although a minority of cannabis users. It's treatable, although there are no pharmacological treatments at present. But it is certainly a significant consideration. When it comes to cannabis and cognition, there is evidence that especially acute cannabis use and chronic cannabis use are associated with decrements in cognitive performance. But those decrements tend to be in certain areas, not global performance deficits. They tend to be relatively small in magnitude from an effect size standpoint. And with discontinuation, they appear to largely reverse. Now, that doesn't mean that if you use cannabis for 20 years every day, all cognitive consequences will immediately remedy themselves. But it certainly seems like promising evidence that cognitive consequences are by no means long-standing or permanent. And then the last point here is that there are blurred lines between medical and recreational use. And even when we think about them separately, the reality is the practice of cannabis consumption often occurs both for medical and recreational use in the same individuals. And so a person may still, even though they're using for medical purposes, still be at risk potentially for cannabis use disorder. And certainly given the high rates of use, and in some subgroups of medical cannabis users, the high THC products that are being used, it's very likely that impacts on cognition will be felt too. So I think that these are issues that pertain not only to recreational use, but also to medical users too. And we have to recognize that medical users are by no means a homogeneous constituency. It's a very heterogeneous group out there. Again, I think that the through line here is we have to think critically about cannabis. It's not a matter of reefer madness or promoting cannabis for everyone. It's a matter of thinking about how do we quantify empirically, carefully the harms, quantify the benefits, and really think about how the harms relate to the benefits in terms of what our perspective should be around medical cannabis, recreational cannabis, and cannabis in general. With that, I'm going to stop. Thank you. I'm happy to take any questions people might have.
Thank you very much, Dr. MacKillop. And I think we'll jump right into the questions. So from Carol, when referring to cannabis, does this always include a component of THC? What if CBD alone is used, or CBD plus a small amount like 0.1 or 0.2 milligrams per kilogram of THC is used?
That's a good question. Certainly, cannabis does not necessarily connote that there will be a high level of THC. Most of the dried flower products do have meaningful levels of THC. And when recreational users are describing their cannabis use, it typically is believed to be of THC moderate to high products, but certainly there are low or no THC products that are out there. So they're not necessarily, that's not necessarily the case.
I guess a follow-up, is it possible, this is from Elizabeth, is it possible to have cannabis use disorder for CBD?
I would say no. CBD does not have, I hesitate to say it has no psychoactive effects, because there can be some experiential effects, and at very high doses it can induce kind of sluggishness, cognitive sluggishness and somnolence, but it does not have any of the intoxicating effects or activity in the brain that's associated with any abuse liability. So I would say that cannabis use disorder for CBD is essentially an impossibility.
So then Elizabeth continues, do you think it would be more accurate to describe cannabis use disorder as THC use disorder, or somehow differentiate which cannabinoid we are talking about?
Yeah, I think that's an interesting point. It's very similar to tobacco use disorder, right? Tobacco use disorder largely reflects actually addiction to nicotine, the psychoactive ingredient in tobacco. But the most common delivery system for nicotine is still tobacco. I think that, people typically, in common usage, I think that people refer to CBD products as CBD products as opposed to cannabis. I think that the distinction is typically that cannabis products have some level of THC. So I think technically that would be a reasonable distinction to make. But I think that in common usage, the vehicle and the compound of THC are so commonly associated with each other that it still remains probably the preferred term. But technically that's correct.
Question from Dr. Suraj Tandon. In terms of cannabinoid hyperemesis syndrome and the comment about bathing in hot showers in possibly reducing CHS symptoms, could cutaneous nociceptive heat, including capsaicin exposure, normalize gastric motility via activation of TRPV1, thus resulting in symptom relief of CHS?
It's certainly possible. I mean, I think that TRPV1 is believed to be the mechanism by which cannabinoid hyperemesis syndrome takes place. I think that, hot showers are typically not a medical intervention for anything other than being cold. So I would think it would be much more desirable to have a direct intervention that might act on the same underlying system. I think that's an interesting idea. I'm not aware of any work on that, but I think that certainly that is the mechanism that's believed to be in play. And so, a cutaneous approach certainly would make sense.
And the second question from Dr. Suraj Tandon, is there any evidence that you can comment on for the use of full agonistic synthetic cannabinoids in the treatment for cannabis use disorder versus partial agonists such as phytocannabinoids?
So there's not a lot of evidence that I can comment on. Because of the CME rules, I feel like I have to stipulate that I'm not making any recommendations and not offering any advice. But I think that the question is a really important one, because there's good reason to think that we have tools at our disposal for treating cannabis use disorder pharmacologically that are very similar to other evidence-based practices. So, when we think about opioid use disorder or tobacco use disorder, the classic pharmacological approach is a replacement strategy using either, for example, methadone or buprenorphine in the case of opioids, or nicotine replacement therapy in the case of tobacco. And the critical thing is that you are using a lower abuse liability route of administration, and that then alleviates withdrawal symptoms without producing any intoxicating effects, although that's not completely true for methadone. And that's and facilitating a person's recovery by ameliorating the physiological dependence. Now, why you would want to use a full synthetic agonist versus a phytocannabinoid, I'm not sure. I think it's an interesting empirical question. One might make the case that some features, the synthetic agonists have to a large extent not fulfilled the hopes for cannabinoid medicine. And one question is whether that's because of route of administration. And another question is whether there are missing ingredients that are present in plant products. And so it's conceivable that a phytocannabinoid preparation might somehow address the disturbed underlying endocannabinoid system more effectively. I actually think it would be a very interesting empirical question. And I'm not sure if there's the basis for why you'd want to try it, I believe, would be basically the entourage effect hypothesis in general, or what's also referred to as the ensemble effect, in which you're getting more recalibration, activity, agonism of the endocannabinoid system by the phytocannabinoid product. But more often than not, the evidence for an entourage effect has not proven to be present. So I think that's more hypothesis than reality at this point.
We'll take one more question from Roman. Is there a general guidance for upper limits of milligrams THC use per day when prescribed medically to minimize risk and not indulge the recreational component?
Yeah, I wish that there were. I think that the recommendation is typically start low and go slow. And I think that if you were treating, if you were getting an antibiotic or if you were getting virtually any other prescription, you would never receive that advice. And I think that there's a lot of risk there as a result. I think we're starting to work towards greater precision here. Just recently a new standard dose of THC has been adopted, the 5 milligram dose, which I think will improve our dialogue around the exact amount that would be relevant. I think that that has been extremely helpful in alcohol research to have a standard drink that's 14 grams of ethanol, and that will also, I think, be beneficial in terms of medical guidance and prescribing. The other critical issue here is route of administration, right? So inhaled cannabis can be quite tricky in terms of measuring how much is actually being consumed because of variability in smoking topography, number of puffs, completeness of consumption, lung volume, VO max. And even if you move to vape pens that have prescribed doses, you get closer, but there can be quite a lot of variability. So it can be hard to give a clear guideline. I think that what's most likely is that in the foreseeable future, we will be able to have clear guidance for things like oral oils or encapsulated products where you can feel confident that the entire dose is being consumed, and it may be definable within that kind of standard dose of 5 milligrams THC. But like a lot of things, like morphine equivalents, I'm sure there's going to be a lot of variability in terms of patient response.
Great, and I think we'll stop there. Thanks to all the speakers that we had today. Tomorrow we have our keynote address, Dr. Robert LaPrairie from the University of Saskatchewan, to talk about the untapped potential of synthetic and naturally occurring cannabinoids. And then the Cannabis Foundation session is looking at practical applications of cannabis authorization in medical practice with Dr. Ramesh Zacharias and Dr. Vikas Parihar. So hopefully you can all join us again tomorrow. Any final thoughts, James and Jason?
Just thank you to everyone who joined us today. I think it was a very stimulating keynote. I hope you enjoyed the risks and harms lecture too.
Absolutely. Looking forward to seeing everyone back tomorrow.
Bye-bye.